Hello, everybody. We're back with another wonderful poster presentation with Todd Brown from the University of Utah School of Medicine at University of Utah in Salt Lake City. He's going to be talking about competitive policies and tax-based and privatized health insurance models. This is a very challenging topic, so I'm really looking forward to your talk. So I'm going to go on mute and disappear and give the stage over to you. So thank you.
Yes, thank you so much. So a little bit of my background, a little bit about me. Before starting medical school, I received my master's degree from Imperial College in London in international health management. And so that's where I started getting my interest in policies and how they can affect quality of healthcare or the cost of healthcare and everything in between. And so, as was mentioned, I wanted to talk a little bit about the tax-based versus privatized models and how pro-competitive policies can affect these types of models. And specifically today, we'll be looking at the United Kingdom versus the United States. And so the reason why this is so important is because healthcare expenditure is at an all-time high, and it's only continuing to grow. And so something needs to be done to stop the healthcare expenditure before it's irreversible. And one way to go about this is through competition. Competition, the goal of it, promoting competition, is to control costs while improving the efficiency, the quality, and promoting innovation within the healthcare sphere. So how does this work? I'm not going to go into all of the economics right now, but on the supply and the demand side, supply and demand determine the market's equilibrium. However, healthcare has specific demand and supply challenges that it faces. On the demand side, you have information asymmetry and moral hazard, where when people are sick, they need care, and they often can't choose where they are receiving the care and the type of care they're receiving because it's laid out for them. However, where moral hazard comes in is that falls onto the providers to determine when and where the care is received, and they're not the ones that are actually paying for the care. On the supply side, there are entry and exit barriers, and there are also choice barriers that the supply side face. And what that means is for hospital and physicians, it's often difficult for people to even enter the market, but after that, it's hard to. There are gatekeepers to healthcare, and we'll talk about that here in a second, especially on the tax-based health care system. How I went about this review is we conducted a review to look at papers that identified competition policies and specifically had their actual effects outlined within these policies. So not theoretical, but actually outlined the effects of the policies. And not all papers were chosen. Inclusion and exclusion criteria is outlined under the methods section. But going to the United Kingdom, the tax-based healthcare system, what that is it's a system that raises their revenue for their healthcare, mainly from taxes, with some non-tax government revenue also being added in. Additionally, tax finance systems, they typically have their own directly managed facilities that they operate and run. And then lastly, most tax systems, they have a GP or general practitioner that is the gatekeeper to help them manage the visits and manage the spending at the health insurance for their health insurance. So there's a couple of different pro-competitive policies that were outlined in more recent years, specifically in 2002. There was a change from a payment scheme on the payment scheme from a reference cost index to an activity-based financing. So this payment by results, or PBR, aimed to overcome providers denying harder, complicated cases and rewarding them for efficiency with payment in a fair way. Now, fair is a hard to define way to look at it, but that was the point of the policy, was to pay them based on their efficiency and their quality. They also, in 2002, in this policy, they started allowing patients to choose where they receive their care instead of being assigned where they receive their care. And then, although this isn't a reform, adding on to that, in 2010, the NHS actually started a website to provide information on the quality and performance of providers to allow patients or the consumers to actually have more knowledge and be able to decide where to go. So all three of these things promoted policy within the United Kingdom. And so what were the effects of these pro-competitive policies? Well, first, it's important to mention there was no change in total expenditure. And so over time, there might have been changes here and there, especially at first, but over time, there was no total change in actual healthcare spending. Second, they found that there were improvements in the actual care that people were receiving. So first, there were improvements in heart attack patients, especially in the locations that had the greatest amount of competition. There were improvements for patients that have had heart attacks. Second, there were improvements in the number of deaths. So there were fewer deaths for all hospitalized patients. And there was also a decreased length in stay for hospital administrations. And importantly, going along with that, there were the readmission rates within the hospitals actually fell. So these improvements in quality were associated with no total expenditure change, which is quite great improvement that they were able to accomplish. However, there were limitations to these evaluations when in determining the effectiveness of the pro-competitive reforms, specifically when looking at there were two different types of competitive reforms that were started at the exact same time, the payment system and the choice in provider. So we're unable to determine which one actually provided the greater benefits, but doing both did show that there were benefits in quality of healthcare received. Now, looking at the privatized side at the United States. So the United States is very different than many of its peer countries in terms of privatized insurance. And then there was a lot of out-of-pocket payments that are required within the United States. So insurers, hospitals, and doctors are private entities where an increase in pay at any level is typically associated with a high pass-through rate to the patients, meaning that if prices do increase, the patients are paying for it typically, no matter what the price, no matter the reason for the price increase. Additionally, the U.S. spends nearly 18% of its gross domestic product on health expenditures. And so, and that's nearly twice the amount of compared to high-income countries per capita. So there's two reforms that I was looking at, and this is the Massachusetts Healthcare Reform and the Affordable Care Act. So looking at the Massachusetts Healthcare Reform, so this occurred and it provided near universal coverage to the citizens of Massachusetts. And it mandated health insurance, it expanded Medicaid, and it ensured minimal credible coverage for all health insurance plans. One of the main competitive changes, however, came on the health insurance supplier side, where there was an online market for consumers to be able to compare insurance plans and shop for the best insurance. So they were more knowledgeable and they were able to actually compare in a better understandable way. And the results of this came with expanded health insurance coverage to more adults, improved access to healthcare, and decreased overall mortality. The reform also lowered the probability of patients delaying care due to costs. And this is very important because the greatest improvements actually came from the socioeconomically disadvantaged groups. And so patients stopped delaying care in these groups and were able to actually get the care that they needed. Now, going on to the Affordable Care Act, they actually did a lot of similar things by mandating health insurance, expanding Medicaid, and then also having an online place for people to shop for their insurance. And so this online marketplace for consumers to buy insurance resulted in less complex contracts where insurers were able to actually compete for the contracts, which increased the competition. And so the Affordable Care Act mandated that every US state has an insurance exchange, and that they regulate the insurance plans by ensuring everyone has the minimal coverage of benefits which allows for consumer choice. And so that is where, again, the competition actually took place, was on the insurance side. And the results of this, they were actually mixed results. And so why they were mixed results was typically because the Affordable Care Act was not enacted long enough for most people to determine if it was actually effective or not effective. This culminated in a lot of people saying it is effective and a lot of people saying it wasn't effective. But when you're looking at all the discussions, a lot of it came down to it wasn't enacted long enough before changes occurred to see if it was actually effective. The positives for it was that a lot of people reported that it did reduce the number of uninsured individuals, especially among the socioeconomically disadvantaged groups, and it improved the quality of care for people, especially those with chronic conditions. However, others disagreed, saying that most of these benefits came from Medicaid expansion and that the middle class ended up facing higher out-of-pocket expenditure and received less support. And so overall, the results were mixed. So overall, what I would recommend to policymakers is, one, no healthcare system is the same. So you really need to take what other countries are doing with a grain of salt and understand that everybody has different health care and health insurance, and how it's set up is different. But ways that you can actually stop increasing the cost and actually improve the quality is increasing patient choice, improving patient knowledge, improving cooperation, because increasing competition can be a challenge, but when you also at the same time are increasing cooperation, it can be very beneficial. And then changing the payment incentives to something that is improving the competition and quality. And so going forward, we're looking at more privatized and taxed health insurance models, as well as I want to evaluate the social insurance, health insurance models, to look at how competition policies affect the social insurance models as well, so we can better determine if they are effective and when they are effective, and how they are effective. So thank you.
That was a really fantastic presentation on a very challenging and difficult subject, and a contentious one at that. So really appreciate you tackling that subject matter and sharing your work with us today. I've commented over here for folks to send in any questions they have. When they come in, we'll forward them on to you. And unfortunately, that's all the time we have, but thank you so much again. And for those of us who are on the call, Todd, this is your second poster of the day, presenting at the beginning and toward the end. So thanks very much.
Thank you. I appreciate it.
Yes. So we're going to be moving on to poster 8. And in addition, before I go on, just want to remind everyone, please do the evaluation. I'm going to be putting that link in a broadcast message, and really need your feedback on the platform and the work that we're doing so that we can help serve everyone better. So take care, and thank you again, Todd.
Thank you.